necessary for all patients.
The pointer of the table there, if you don't mind. So this is a little bit of a continuation from the prior part is, do we need to give radiation therapy to every patient after lumpectomy? That was supposed to give it in Dubai, but I had changed the slide, so I took another talk. So I do apologize for the change in the title. We know from 6 prospective randomized trials that were done in the past that compared lumpectomy to mastectomy, that lumpectomy and breast preservation gives you exactly the same survival as mastectomy. And one of these trials, which is the NSABP P06, had 3 arms in that study. And the purpose was to see if the patient who had mastectomy had the same result as the patient who has lumpectomy. And they added another arm, which is lumpectomy alone, to see if there's a need for radiation therapy after lumpectomy. And when they analyzed their data, they found that the local recurrence in the patient who had the lumpectomy was approximately 40%. And you could see them here in the upper graph. And those who did have radiation therapy, the local recurrence was approximately 13.9%. Although in their study with that small number of patients, the survival was the same, but the local recurrence was significantly higher when they did not give radiation therapy. And based on many of these results, the NCI consensus 1991 was published in Journal of American Medical Association saying that in order to do breast conservation, which is the preferred operation because you keep the breast, you have to excise the tumor. At the time it was level 1 and level 2 node dissection, and you have to radiate the breast. And there are approximately 6 or 7 other studies that were conducted trying to look if they could omit radiation treatment from the breast. And all of these studies have shown that the risk of local recurrence is significantly higher in those patients who did not have radiation therapy, is at least between 20 to 40%, and probably 4 to 5 times higher than those who got radiation therapy. And it was not until the early breast cancer trialist group looked at all these studies together and ran a meta-analysis and showed there is a difference in local recurrence in the patient whom they did not get radiation therapy. And that difference in local recurrence eventually, 15 years down the road, translate into a difference in survival. So the delivery of radiation therapy does impact survival. And that difference in survival, when you omit radiation therapy in patients who are node positive, is even larger. But we know that all breast cancers are not the same. And the first person who started questioning that issue of delivering radiation therapy was the group from the CLGB, and the study was run by Dr. Kevin Hughes, and I'd like to thank Kevin for sharing his slides with me so I could present them to you, where he ran a study in patients who are 70 years of age or older. These patients were all stage 1 clinically. They had a tumor less than 2 centimeters in size, or 2 centimeters. They were clinically node negative, and they did a lumpectomy to negative margin, no income tumor, and the vast majority of these patients were ER positive. The patients were stratified by age and whether they had a node dissection or not, and they were randomized to have surgery, and after the surgery they were randomized to have radiation plus tamoxifen or only tamoxifen. And this is the description of the group, approximately 300 patients in each group. And the most important finding, they published their data most recently in 2013 in the Journal of Clinical Oncology with a minimum of 11-year, median follow-up of 11 years, and they found, yes, there's a difference in local recurrence, but that difference in local recurrence did not impact the survival of the patient, did not impact the mastectomy rate, and the local recurrence in the patient who did not have radiation therapy was only 10% versus 2% for those who did have radiation therapy. Now, another study was recently presented in San Antonio, and it was under the leadership of Dr. Michael Dixon, and Mike Dixon was kind enough to give me his slides, and this is the Prime 2 study. It is similar in design to the Kevin Hughes study, but in this study there is 1,300 patients. The size was a little bit larger, 3 centimeters or less. All of these patients were ER or PR positive, insisted on a negative margin, and all of these patients received hormonal therapy. And the patients were randomized to either whole breast radiation or no breast radiation whatsoever. The local recurrence at 5-year follow-up was 1.1% for those who got radiation, and for those who did not get radiation, the local recurrence was only 4.1%. And more importantly, the survival was exactly the same for both groups, and you could see the survival curves are superimposable. Then they ran a meta-analysis in their study, and the meta-analysis included the size of the tumor, the grade of the tumor, multiple other factors, and they found that in patients who have a very high ER positivity, the local recurrence without radiation is only 3.2%. So it's those patients who have a very low ER have a significantly higher local recurrence at 5 years. And their conclusion was for that study that omission of whole breast radiation in women who are older than 65 and pathologically node negative, hormone receptor positive, after breast conservation therapy and endocrine therapy is 4%. And if you look at the high estrogen receptor, the local recurrence is only 3.2%, and they think that you can safely exclude radiation therapy from those patients. There are 9 modern trials that looked at this specific issue of omitting radiation. These modern trials have common characteristics in their patient selection. First, in the vast majority of these trials, the patients were older than 50 years of age. Few of them included older than 45. In the vast majority, the tumor was 3 centimeters or less. All of these trials were estrogen receptor positive and had clinically or pathologically no negative. And you could see the data on these trials, and if you look at the last column in that table, which is quite busy, the local recurrence, yes, is significantly decreased by radiation therapy, but in those who did not have radiation therapy, the local recurrence at 5 years is in the order of 5%, and if you wait till 10 years, it's only 10%. So do we have to radiate 90% of the patient unnecessarily to get a benefit of maybe 4 to 5%? Now, the first question that probably comes to your mind, an intelligent audience who said, you just showed us that the omission of radiation therapy impacts on survival. So how am I thinking of omitting radiation therapy if it impacts on survival? But the early breast cancer trialist group realized that there were too many studies that were looking at a particular group of patients, and they reran their meta-analysis in 2011. And they showed, yes, there's a difference in the local regional recurrence in patients who do not get radiation treatment, but that difference does transmit into difference in survival, however, at a smaller rate. But then they looked at their analysis and they categorized the patient into 3 categories. High risk for local recurrence, intermediate risk for local recurrence, and low risk for local recurrence. And the criteria they used are the age of the patient, the size of the tumor grade, the ER status, the extent of surgery, and the tamoxifen use. And they did show that in the patients who are at high risk of local recurrence, that difference in local recurrence over 10 years eventually translates to a difference in survival. But when they looked at the intermediate group, there was a difference in local recurrence. But with time, that difference in local recurrence did not translate into a difference in survival. You could see the difference in survival is very similar on long term. That's for the intermediate group. For the low risk group, the same observation was noticed. Yes, there was a difference in local recurrence, but there was no difference whatsoever in survival. And now we know that we have molecular subtypes. These molecular subtypes do have a difference in local recurrence. But if you think of the patient that I'm presenting to you that have been most of these studies, these are most likely the luminal A subtype. And that's why currently, if you look at those studies that looked at local recurrence, the luminal A has a very low local recurrence, very similar to the study that was presented by Dr. Kevin Hughes and to the study by Dr. Michael Dixon. So I think the use of tamoxifen in the patient who have low risk by oncotype also shows you that there's a very low risk of local regional recurrence. And you could see that patients who have a high risk by oncotype have a 15.8% local recurrence. Those who have low risk by oncotype have a 4.3% local recurrence. So there are genetic criteria that now we could use to tell us who are the patients at the low risk for local recurrence. So in summary, radiation therapy definitely decreases the incidence of local recurrence. And the incidence of local regional recurrence without radiation therapy in the intermediate risk and low risk is less than 10% over 10 years. And if we use those criteria, the age, more than 50, tumor less than 3 centimeters, node negative, estrogen receptor positive, maybe low grade or intermediate grade without LVI, we think that the radiation therapy will not impact on their survival, and these patients will do well, and perhaps we should consider omitting radiation therapy in this age, in these particular patients. And we are currently running studies in the US looking at that category of patient where we're omitting radiation therapy. And I think genetic profiling is going to help us more detect those patients in whom we can safely omit radiation therapy without impacting on their survival, and perhaps having just a little bit higher rate of local